My name is Giles Peake. Welcome to this recording of the inaugural SNOOPI webinar held on the 12th of January 2026. We had some technical difficulties at the beginning of the meeting, so please excuse this short post-production introduction. The SWEEP nitric oxide observational and prospective investigators welcome you. Please email me, gilespeake@ufl.edu, if you would like to be part of the SNOOPI research group. And we've yet to prove that it definitely works. I think we're fairly certain it doesn't do any harm. Personally, I'm sure it works, but we need to investigate how it works, if it works, who it works in, and what the correct dose is. So the purpose of this webinar today is to discuss all of the biology of nitric oxide and the sweep gas, which we call SNO, and to discuss the studies which we might do in the future. And then to have a discussion at the end, which will be led by Dr. McLaren, as Dr. LaRusso has to go and do something else, and myself, to how we can take this forward. So we're going to start by recapping the biology, and I'm going to call upon my colleague Sasha Vasquez-Colon to do that. Following that, Dr. LaRusso is going to talk a bit about his ideas going forwards, and then introduce the laboratory background, which is going to be Dr. Alvaro Rojas from University of Michigan from the Bartlett Lab, and Dr. Baczynski and Roberts from the Arriva Lab in San Antonio. So without further ado, I'm going to hand over to Dr. Vasquez-Colon. Thank you, Sasha.
Good morning, everyone. Can you hear me?
Clear, yes.
Okay, good. Let me share my screen real quick.
Yeah, we can see it.
Perfect. Okay. Well, good morning again. I'm going to be talking about the biology of nitric oxide and the clinical experience of the use of nitric oxide in the sweep gas in the ECMO circuit. We will review the nitric oxide biology, understand the ECMO-related NO relationship, and discuss clinical experience with nitric oxide in the ECMO sweep gas. First of all, what is nitric oxide? Nitric oxide is a gaseous free radical that diffuses freely across cell membranes. It also acts locally and has a very short half-life. As you can see here, it is involved in multiple physiological processes, including inflammation or transmission, platelet aggregation, immune response, reproduction, and multiple physiological processes. In terms of the synthesis of nitric oxide, it is enzymatically generated from L-arginine by a family of what's called nitric oxide synthase. And these NOS, as they're called, are expressed in different tissues. There are three different isoforms. One is the endothelial, one is the neuronal, and one is the inducible. The endothelial is found in the endothelium, and it produces nitric oxide in small amounts to regulate vascular tone. The NOS is found in neurons, and it functions in neurotransmission, and the inducible NOS is expressed in immune cells and produces large amounts of NO during inflammation or infection. After that, NO can later target enzymes and proteins in the cells by activating soluble guanylyl cyclase and generate cyclic GMP. It does that through two different pathways. The classical pathways end up in cyclic GMP, activating protein kinase that leads to smooth muscle relaxation and vasodilation. And there is a non-classical pathway that presents in other parts of the body, including the vessels, to inhibit platelet aggregation and affecting the immune response.
Sorry, Dasha. Sorry, Dasha. I would ask all the participants. Sorry, I would ask all the participants to shut down the microphone, please. Just put mute all the microphone, please. Raja, please
Yes,
put
I
your
can do that.
microphone. Thank you.
Okay, perfect. In terms of the benefits of nitric oxide, we can see it can dilates the vascular endothelium, decreases the platelet activation and aggregation, decreases reactive oxygen species, decrease the pro-inflammatory cytokines, the leukocyte adhesion, and neutrophil endothelial interactions. It can also assist in inhibition of apoptosis and decrease of myocardial injury. As we can see, there are multiple benefits of nitric oxide. Now, what happens with nitric oxide when a patient is placed on ECMO? As we know, when blood contacts the ECMO circuit, it encounters a non-endothelial surface, and that leads to an inflammatory response. And there's also high shear stress and hemolysis related to it. All these actions lead to a disruption of the normal nitric oxide biology that we just discussed, and a decrease in bioavailability of nitric oxide in the body. This decrease in nitric oxide bioavailability contributes later to platelet activation, consumptive coagulopathy, and circuit thrombosis risk, which ultimately also leads to vasoconstriction in the body. Then why should we deliver NO into the circuit? There are certain benefits that have been described in terms of why we should do it. First, is there it can help restore that nitric oxide signaling lost due to the hemolysis and the scavenging of the NO by the free hemoglobin, reduce platelet activation and inflammation, reduces fibrin deposition, and also improves the oxygenator lifespan. Now, what do we know so far of the use of nitric oxide in the circuit in patients on ECMO? There are pediatric studies and experimental studies that suggest that nitric oxide is acceptable and safe to use at low doses. It has also shown to decrease oxygenator and circuit changes and to decrease platelet activation. And we will go over some of those studies shortly. In terms of safety considerations, the potential risk of using nitric oxide in the circuit is hyperglobulinemia, bleeding concerns, and concern for rebound effects if it is stopped abruptly. For this reason, whenever we have patients on ECMO and we use nitric oxide, we monitor methemoglobin levels. Moving to the clinical experience on ECMO, I'm going to start with this first study that evaluated whether nitric oxide could improve anticoagulation in ex vivo models of ECMO and cardiopulmonary bypass. In this case, they used human whole blood circuits that were exposed to nitric oxide at 30, 50, and 80 parts per million alone or in combination with heparin. They later assessed for coagulation, platelet function, circuit performance, and inflammatory activation. What they found was that nitric oxide alone was unable to prevent thrombus formation in either model, necessitating a combination therapy with heparin. And overall, adding the nitric oxide to the heparin did not significantly improve anticoagulation or hemocompatibility, but they did find that in ECMO circuits, higher nitric oxide doses produce a dose-dependent reduction in platelet aggregation, while low-dose nitric oxide help preserve platelet counts in the circuits. And those circuits that were treated with nitric oxide also showed a reduced inflammatory cytokines, in this case IL-8 and TNF-alpha, suggesting that potential anti-inflammatory effect. These benefits were not seen in the cardiopulmonary bypass group. The next one is a pilot study, and in this one, they described their experience with 30 children who received ECMO support with 20 parts per million of nitric oxide in the circuit. Here, they compared those 30 patients who had received ECMO with to those who did not receive nitric oxide the 3 years prior to that. So that was a total of 120 patients. And in this one, they concluded that SNO is safe and does not cause any adverse effects. And there were no differences between the two groups. In this other study, they wanted to evaluate the clinical effects of nitric oxide added to the oxygenator of children on ECMO, and this is a pre and post cohort study of pediatric patients as well. They had a total of 393 ECMO runs, of which 49% received nitric oxide in the circuit and 51 did not receive nitric oxide in the circuit. In this one, they found that nitric oxide through the circuit was associated with a decrease in the oxygenator circuit changes with an absolute risk reduction of 0.63 and confidence interval of 0.42 to 0.93. They also observed that the less risk of neurologic injury, especially in those patients post cardiac surgery, with an absolute risk reduction of 0.5 and a confidence interval 0.26 to 0.96. And they did not see any survivals difference, but they did see that reduced in circuit complications. This one was actually published from our center. It is a single center retrospective review. And here we had two groups, one group that received nitric oxide and another group that did not receive nitric oxide in the circuit for a total of 49 patients, 19 in the SNO group, and 30 in the patient that did not receive nitric oxide in the circuit. In terms of patient demographics, there were no differences between the two groups in diagnosis and demographics. We did see in terms of primary outcomes, we were looking at the safety of adding the nitric oxide to the sweep gas. And so we were looking at that median daily methemoglobin levels, there was a difference between the group that had nitric oxide in the circuit and the group that did not, with a p-value less than 0.001. But this difference was not clinically significant in our patient population. In terms of secondary outcomes, we looked at the blood product administration that the patients received as well, and we did see it was not statistically significant, but there is a trend that of less requirement of fresh frozen plasma in the patients that did receive SNO in the circuit. Now, we have seen that all these studies in pediatric population, but there isn't much literature in the adult population and the use of nitric oxide in the ECMO circuit. However, there are published studies on nitric oxide in cardiopulmonary bypass in adult patients showing promising results, such as myocardial protection, improvement in hypoxemia, and improved levels of vasoactive inotropic score. And these are described in this set of different studies that I'm not going to detail due to time limitation. So with this, we did look at the adult population at our centers that we have used the nitric oxide in the circuit to see if there was a difference, if it is safety, the same thing that we did for the pediatric population. We had a total of 16 runs, 12 patients that received nitric oxide in the circuit, 4 patients that did not receive nitric oxide in the circuit. There were no differences in the patient demographics, and we did not see a significant statistically significant change in the methemoglobin levels, and again, no clinical issues with the patients either. In terms of ECMO complications, there were no differences in ECMO circuit changes, bleeding episodes, clots in the ECMO circuit, or stroke events in those two groups. And we also looked at the transfusion requirements. And again, we did not see a difference in blood product administration, and there was no difference in survival to hospital discharge. Again, a limitation of this study is that we only had 12 patients, 16 total, but 12 in the SNO group and 4 in the no SNO group. And it's a very small group to have good numbers. So in summary, we do need prospective randomized trials, and the effects on adult ECMO outcomes are also less well studied or understood. And that is all.
Thank you very much. That's an excellent gamble through the biology, which is clearly very fundamental. It's a fundamental biological molecule that keeps our endotheliums working and our platelets, from giving us strokes. So thank you very much. Now it's my pleasure to introduce Roberto Larusso. Roberto is a professor of cardiac surgery at the University of Maastricht and co-founder of EuroAlso. And I'd like to call on him to, slightly out of order, to give his ideas about how we could investigate this in the laboratory by collaboration, and then to introduce Dr. Alvaro Rojas from the University of Michigan, from the Bob Bartlett laboratory. Thank you.
Thank you, Giles. Thank you, and welcome everybody to this very interesting, I would say, extremely important webinar regarding the potential of NO and our daily activity in ECMO patients. My intention is just to, try to promote some preclinical studies, and I think we have quite an important and potential task, and I think I can show you just to give you an idea what is our possibilities is to have and show you this case report that we published just a few years ago during a COVID patient, but just to give you an idea about I think the effect and therefore what we could still investigate, because at the end of the day, we know that NO works, but I think we should really go back to I don't want to say the bench, but certainly to some more, let's say, comprehensive and consistent preclinical. So in this patient, we had, a COVID-19 patient, we had very bad pulmonary situation. And this patient, as you can clearly see, he developed a right ventricular dysfunction and of course, desaturation. But then we started, and as you can see here, right ventricular diameter, dilated, tricuspid insufficiency, severe. So we started NO because we thought that with NO and starting in this patient, we could try to avoid a switch or conversion to VA. And look, after 12 hours after NO administration, the right ventricular diameter was normal, tricuspid regurgitation was absent, and by the way, with a very important improvement in the gas exchange. So just to give you a very immediate idea that NO has really a big potential in our patient, not only about the vascular effects, but also in terms of the circuit, as Zasha clearly pointed out, and about the pleiotropic effect of NO regarding platelet activation and so forth. The problem is that we have to go deeper. And my proposal would be to investigate at a broader level the effect of NO administration in the circuit regarding, obviously, the biological effects and consequences, but also investigating clearly and deeper the effect, for instance, on the hemodynamic consequences, particularly on the right ventricular function. As I showed you before, in that COVID-19 patient, I think NO could be extremely, extremely promising in enhancing the right ventricular function in severe RDS, which could make or could become a game changer. The problem is we need a very detailed and in-depth analysis. So my proposal would be to run a multi-lab investigation. And the reason why is that we should look at the effect of NO administration in our oxygenator or circuit and look at the effect and the impact and influence on right ventricular function and, of course, on vasculature on the pulmonary arteries. But based on that, I think if we would have the same results in 3-4 labs, I think that would be a definitive proof of what we could get and we could obtain with the NO administration in these patients. So we should have the same protocol in the 3-4 labs, inducing right ventricular failure, and of course associated with a severe RDS again model, and then start the NO administration, looking particularly not only at the biological, as Zasha showed clearly, because I think that is quite accepted. I mean, it's quite demonstrated that NO is obviously has so many pleiotropic effects about the platelet, about a lot of, but I think we should really also focus on the hemodynamic effect, on the right ventricular function, which is absolutely Achilles heel. Sorry, can you please mute the microphone? So that is my proposal, a multi-lab, like a multi-center study, inducing acute right ventricular failure and pulmonary, of course, distress like RDS in animal model, having the same protocol across these 3-4 labs, and looking at the effects and measuring carefully all the hemodynamic aspects and parameters of the right side of the heart, because these can be the additional, let's say, conquer additional promising effect of NO in these patients, particularly in VV and severely ill RDS patients. So having said that, so I hope that this idea will be shared and agreed among the people interested in doing research with the NO and the animal lab. I pass the word to Alvaro Rojas, who is the director of the lab of the Dr. Bartlett's lab, which so much has provided and done along the years. And we, again, take the advantage of this occasion to express all our sorrow and loss for Dr. Bartlett's death. Alvaro, please.
Good morning, everybody. Giles and Roberto, thank you for the introduction and setting up this important webinar. Hope you guys can see my screen.
Yes, we can. We can see it.
Okay, perfect. Okay, great. Okay, I see so many friends in the webinar. Welcome. Let me take a few seconds just to acknowledge Dr. Bartlett, who was a pioneer and actually one of the persons with Dr. Gail Annie, who introduced over 25 years ago the concept of nitric oxide in extracorporeal circuits. Today, I'm going to talk about the most recent study. This is the lessons from a large animal project that we did doing VV ECMO for 14 days without systemic anticoagulation. Of course, I have to disclose this project was funded by the NIH. We ended this year, and then we also have a couple of projects associated with nitric oxide releasing ECMO circuits with Nitrix and BARDA. Another project related to developing artificial lungs and prolonged organ preservation. And another very important project related to nitric oxide is with Dr. Launer from the University of Michigan Department of Pharmacy, who is studying a novel high-flow nasal cannula nitric oxide generator system. So with that, I think that it's important that we review why we're here. So thrombosis and bleeding during ECMO is a major complication. This data comes from the ELSO registry assessed July 2024. Clotting, as you can see, both in adults, respiratory and cardiac is an issue. We have about 25 to 33% of clotting complications. Bleeding is also a problem, but primarily is CNS bleeding. In neonatals is a higher and most concerning rates than in adults. However, as we can see in patients, in adult cardiac patients, they're associated with high bleeding incidence compared to the other ones, most likely because of the higher flows that need to be used to support these patients. So what is accepted is you provide to the patient platelet or clotting factor supplementation, or you stop the anticoagulation because the risk is accepted and overweights the benefit for the patient. It is important to say that ECMO without systemic anticoagulation has been done, but in specific circumstances. And I need to also say that it's for a short periods of time. Also, not too many groups have provided data below 3 liters. So most of the patients without systemic anticoagulation are between 3 to 3.5 liters. And this is a very historical paper with Dr. Bartlett and our team in Michigan give the concept of what is needed. So the most important thing here is heparin coated. The main issue is flows or design of the devices that create clotting. And then in order to, once you fix all of that, you need to smooth the stagnation of the flow and then prevent platelet consumption and therefore thrombosis. So Dr. Vasquez provide a very nice summary of the physiology. However, we need to keep in mind that our normal endothelium produces nitric oxide fluxes between 0.4 and 4.8 flux units. And that's what we just try to attempt when you have production of NO or supplementation of NO, either through a sweep gas or with modified surfaces. So I also like this picture because Dr. Anik and Dr. Bartlett demonstrated in a rabbit model about 25 years ago, or 26 years ago now, that if you combine NO releasing, you can see the group here where there is no adhesion of platelets and limits thrombosis. With that in mind, our group has done a lot of studies between doing coding and of DBHD or NO donors, and in addition to argatroban. And then most recently, we have developed a nitric oxide electrochemical generator, low-cost system that produces nitric oxide. We published this in a porcine model of cardiopulmonary bypass with recovery for up to 7 days. And then we combine all of this and we say we're going to call this nitric oxide surface anticoagulation, aka NOSA. Today, I'm going to talk about a specific study, 14 days VV ECMO without systemic anticoagulation. This is a timeline. We have technically 3 groups, 4 animals in each group, all going 14 days. That was the target. We did the surgical instrumentation on the general anesthesia for VV ECMO access. We started device flow and sweep flow, only give heparin to all the animals prior cannulation. And then we collected hemodynamics, the time for the circuit to fail, characteristics of the ECMO run, coagulation markers, platelet activity, and NO toxicity. And we assessed this over 14 days, and we set the target flow to be 1.2 liters per minute. At the end of the study, we recover organs and study the system. And we also have a couple of criteria here. One is a device resistance more than 5 times will be exchanged, and only 1 exchange will be allowed in the first 6 hours, and I will tell you why. ECMO flow drop more than 50% without changes in the RPM, decrease in the oxygenator function less than 95%, or any issue that was distress to the animal, including unmanageable pain or bleeding. So again, as I say, 3 groups. One is the heparin, is the standard system, trying to maintain anticoagulation about 1.5 times baseline. This is with a heparin infusion over the experimental time. Then we did the NOSA, which is basically the combination of nitric oxide releasing circuits that goes cannula, tubing, connectors, and in the addition of nitric oxide in the generator and the sweep gas. And then we saw the opportunity to test just the sweep gas, 100 ppm over 14 days. As I mentioned, we collect data continuously, and we're going to present it every half hour, every day. This is a schematic of the circuit. I don't know if you guys can see my pen here, my laser. Let me see here. Yeah, my laser. So we're going to start, we put a drainage cannula in the jugular vein. We have the M pump, which is a collapsible roller pump, goes into an oxygenator. The oxygenator is the Capiox FX baby from Terumo. Important things here. It's an oxygenator, not for ECMO. It has an integrated arterial filter of 32 microns, and it's X-coated, rated flow 1.5 liters. So we know we're going to induce thrombosis no matter what. That was the whole point. Then in the oxygenator, one group, which is the Nogen, had 100 ppm from our generator into the sweep gas, and then return back into the femoral vein. So this is dual cannulation VV ECMO. So outcomes. You can see here the heparin control. All of them, the 4 oxygenators in this group and in our 5 days study also, had to be exchanged within the first 4 hours. None of the animals survived the 14 days. The longest was around 9 days, and all of them had bleeding complications. When we study just the sweep gas, we have an average of about 216 days. That's about 9 to 10 days. And 2 animals lasted the 14 days study. And of course, as we expected, combined sweep gas NO in the sweep gas plus NO releasing materials in the circuit, we were able to increase to about 290 hours, and 2 animals also survived 336 hours, which is the 14 days. As you can see, there was no significant difference between the nitric oxide releasing groups compared to between them, but there's a significant difference between heparin control and both of the nitric oxide groups. When we look at the systemic effects of nitric oxide in this model, so as you can see, unexpected, the heparin, you can see there the target and the average ACT values. The green line shows the baseline ACT in our animals. And as you see, the sweep gas NO doesn't have a significant effect, and the same thing as the NOSA with the Nogen. Looking more in detail up to a platelet count, this is normalized to baseline, and I want to remind some of the people here, sheep has a lot of platelets, so and they vary a lot between animals. So that's why we needed to present the data as normalized data. But the range is between 260 to 600,000 platelets per microliter. As expected, on day 1, there is a platelet consumption, and we maintain and recover the platelets actually quite quick in the nitric oxide groups. And as we're failing with the lungs, the platelet consumption start decrease, and then we just lose platelets. But that's a standard bell shape that we'll see when we use ECMO system. Most of the platelet count recovers after 4 days of support. When we look at the platelet aggregation, which is basically a measurement of platelet function, we didn't see any difference between the groups as is stated here. And of course, important, at the beginning of the ECMO, dilution and the extracorporeal circuit does decrease the platelet aggregation or platelet function. Then we measure markers of thrombosis. Plasma-free hemoglobin was measured over time, daily. What is important here is as the system were failing, we see in the heparin control an increase in plasma-free hemoglobin, but no higher than 25, so that's not as clinically significant. Most important, all of the nitric oxide releasing groups have very low plasma-free hemoglobin over time. And then we measure methemoglobin as a toxicity for nitric oxide. In all of the groups, it was less than 1.8%, which is not clinically significant. This is overall the 14 days of support. We did see complications as I measured in the heparin group. All the oxygenators needed to be exchanged. Bleeding was our main problem. We have to stop the 4 animals early because major bleeding, primarily in the groin, in all of the animals. And then with the current donor of NO that we're using is DVHD and has a potential carcinogen in rodents. So right now, my team, led by Dr. Launer Sorba Orsi, which I think is in the webinar, and collaborators at chemistry and pharmacy develop a new NO donor called SNAD, where she's able to impregnate and swell ECMO circuit components with great success. In conclusion, NO-releasing systems in an ovine model of VV ECMO without systemic anticoagulation is possible and effective. It increased the circuit patency. There is no need to have any oxygenator exchange at the beginning. We didn't have any hemorrhagic complications. The lack of NO system effects and toxicity need to be studied, but we didn't have any issues with our animals in both groups. I think that all of this is a suggestion that we are, as Dr. Anik and Bartlett proposed, with mitigating the activation of platelet and the lysis of red blood cells. As I mentioned, we need to study safer NO donors, and I think SNAT is the new kid on the block. And I need to thank my whole team, especially Dr. Bartlett, our founder, my collaborators in the lab, Dr. Palke, who leads the BME group, and Dr. Launer Sorba, who leads the thrombogenicity, and many other co-investigators, including Professor Meyerhoff from chemistry, who have developed this technology with his team throughout the last 20 years. Thank you very much, and I'm happy to have any questions at the end of this.
Thank you, Alvaro. Very, very interesting presentation. I would like to invite everybody to provide questions, comments using the chat. And I think, what is your experience? I may start with the first one. Is your experience with hemodynamic assessment? I mean, did you look and did you observe, did you record any effect on the right ventricular function as I showed you before?
Yes, so that's an excellent question. And for this study, we did not. These were healthy animals. However, in the current grant that we're doing with Dr. Launer, Greg Launer, we are recording that. And the main issue here, why we input it is because on ECMO, we go VVA with high risk of embolism, sucking from the lines, from the measurement of the catheter. We don't have a good setting, and we have complications. But in the high flow nasal cannula study, where we're providing anything between 20 to 40 ppm on healthy animals, and we put a PA catheter, we saw a significant decrease in pulmonary artery pressures. There were maybe, if the average was a drop about 10 points in the mean arterial pulmonary artery pressure of healthy animals. We observed these animals for only 72 hours. And we did a group of five, actually four now. One of the animals have a preconditioning situation that we saw as a chronic lung injury, like fibrosis of the lungs. And we saw a little bit of pulmonary edema in that animal at the lower pressures. This is a healthy animal. And then the other three, the drop was there about 10 points from the normal. So we're running in mean pulmonary artery pressures between 12 and maybe 15. Those animals didn't have any pulmonary edema at necropsy. I do agree that we need to have a disease model because the physiology changes between a healthy animal or a disease model. But what we have seen from the right side in this is that nitric oxide has a benefit. And I can mention that through other studies where we were testing the artificial lung with nitric oxide releasing components, where we induce occlusion of the pulmonary artery, and it does changes a little bit, but our model is more obstructive. So it's hard to really translate that information. But yes, I think that we're looking into more details about the high flow nasal cannula with healthy animals. And most likely, I agree with you 100%. We need to study this more with diseased animals. With sick animals.
Yeah, thank you very much. I agree.
Roberto.
Yes, please. Yes, I replied to your question, Giles. We use not in the sweetgrass, so we just administer not in the sweetgrass. But that's the reason why I think that would be another very interesting test in the animals to compare the sweetgrass versus the other administration and look whether you have any differences. I think that would be another very interesting experimental model. But I agree with
for sure.
And with Alvaro, I agree that we really have to try to work with the sick animals, so with some disease model, because this would help us a lot. So we have a question here. Alvaro, can we extrapolate the thromboprotective and circuit protective role of SWEEP to VA also, not only in DV? What do you think, Alvaro?
100%, 100%. You can extrapolate this. It works. The main reason we didn't did VA ECMO is because it's a little bit more complex for us to have these high flows in the arterial in these animals over that prolonged period of time. But when we published the study on CPV, we using 500 ppm of NO during cardiac surgery, and the results were beautiful because these animals didn't have a significant effect in their FiO2 ratio. They were much better. They recovered faster, extubated faster, and the more survival was a little bit better, but not significant compared to other groups without nitric oxide. This is about 4 hours of CPV with cold cardiac arrest in pigs. So it does have a little bit more of the clinical implication there. But yes, you can extrapolate this to VA ECMO, VAV ECMO, everything I would say with extracorporeal circuits. And I think that this current data that I hope to publish this year with my team at Asayo is that it's a synergistic effect. You have an effect from the ECMO's components that you can easily modify it, and we can basically do it with the connectors, which all we know are very thrombogenic, and some of the cannulas, and then add SNO, and then you have complete coverage. Now, it's interesting that.
I think I was sorry because we are a little bit on delay. We should move. Maybe you can add your comments in the chat so everybody could get your additional comment. Sorry that I had to interrupt you, but we have to move on with the next speaker, who is Andrei Baczynski, a very well-known lung injury research scientist, general surgeon, and now is also the founder and director of the Autonomous Reanimation Evacuation Research Program, so-called AREVA, at the Geneva Foundation. So Dr. Baczynski is obviously a worldwide renowned expert in ECMO and has a fantastic lab. He's doing a lot of work. So I'm very glad and really with great pleasure to introduce Andrei for the presentation of SNO for echo to without systemic anticoagulation experience in translational multi-day swine studies. Andrei.
Thank you, Dr. LaRusso. Hopefully you can hear me. If not, please let me know.
We can hear you very well.
Thank you for inviting us to present today, Dr. Roberts and I. As we speak about this topic, we need to recognize that this molecule that was called the miracle molecule is really intriguing, but it has applicability to various injuries and organ systems. So we need to be clear what is it that we're discussing today, and we'll try to narrow that down. Next slide, Taryn, please. First of all, we don't represent any official entities in the US in our opinions. These are our opinions and our opinions alone. Next slide, please. I'd like to introduce the concept with which the AREVA Institute was founded based on civilian and military perspectives. We have heavy involvement in point of care and point of injury translation of critical care interventions. And if I had to briefly mention what are we about, our research institute really would like to take ICU interventions from the hospital to the beds, to the point of injury, or to wherever they are needed, either in a civilian pandemic situation, for example, or military situation where an injured casualty needs to receive life-saving interventions at the point of injury. And so we have a variety of involvements in this area. Next slide, please. For example, one device that integrates a variety of capabilities that is used in the war in Ukraine right now is this device on the right, made in Canada by Thornhill Medical. And it's an integrated device that combines a variety of ICU interventions and could also be a platform for delivery of nitric oxide in this particular question that we're discussing today. Next slide. So the Arriva Institute really have multiple departments and strategic priorities, but in line with the topic of the day, nitric oxide is really considered in multiple use cases. Next slide. So we look at various applications of nitric oxide to extracorporeal life support capabilities. We involve it in device development. We use it and plan to use it in a variety of models, from polytrauma to traumatic brain injury, so not exclusively for lung injuries, but in this case we have used to date primarily in lung injuries, primarily ARDS models due to trauma or other conditions. Our translational ICU capabilities are quite wide. We use almost exclusively swine, and all of them are severely injured, anesthetized, and usually the study formats are 72 hours. Most of what we do at Arriva are tailored to real-world problems, such as the war in Ukraine or Gaza, and we are trying to take the NO molecule to various areas that it has not been used before. Next. So as we talk about the use of nitric oxide, Dr. Vasquez Colon gave a good overview of a variety of different use cases already. So I would like to remind everyone that as we present our data, we need to clearly explain what is the condition that we're using it in. So almost all of the data that Dr. Roberts will be presenting is pertinent to swine studies. It's pertinent to either uninjured or injured animals with ARDS. Somebody posted in the chat whether it's applicable to ARDS, what we've seen so far. We need to be clear about the blood flows. Data you will see will be applicable to about 1 liter to 1.5 liter blood flow. The data that you will see will be applicable to exclusively vena-venous conditions. I do agree that some of this can be extrapolated, but considering that many applications are used with a variety of different devices, a variety of different settings, cardiac and more invasive centers, we need to be very specific about what is it that our data relates to clearly. And then we of course need to describe the comorbidities and conditions. My concern with using NO or any experimental or new treatment in the clinical domain faces the challenges of multiple different variables that are undergoing with the critically injured patient. So it's going to be very difficult to discern the positive or negative effects of the nitric oxide or any other intervention to just one variable. And so we need to track all the other variables that are ongoing. And finally, I will say that the nitric oxide literature is somewhat deficient because a lot of the work that has been done back in the even 70s and 80s has not been published, as it work in the Soviet Union was never medlined. And so I saw one paper from a post-Soviet group in Dr. Vasquez Colon's review, Dr. Kamenshikov. But it's important to realize that some of what we do has been used before, and so reviewing the literature is useful. But as far as Arriva's work that Dr. Roberts will present from now on, we are trying to use nitric oxide exclusively in the sweep gas, in portable applications, and we need to make sure that we're clear about the conditions under which we investigate this molecule. Dr. Roberts, please continue from here. Thank you.
Okay, thank you, Dr. Buczynski, and thank you, Dr. Peak, for putting together this opportunity for discussion. For the remainder of our time, I wanted to take the group through a recent study that we published in a SIO journal to kind of give an example of the types of translational studies that we're conducting at Arriva. I'll then touch on some other models that we've conducted since this study that are ongoing and in publication, and touch on some potential areas of collaboration that we would like to pursue with other clinical groups. So this is a study where we looked at using nitric oxide in the sweep gas at 80 parts per million concentration in combination with a circuit coating on the circuit tubing that generates nitric oxide from endogenous donor species in the blood, such as glutathione. And in this study, we were first looking at just safety of the approach. And so we're working in a uninjured model in swine. So we had 6 swine that had the nitric oxide and the sweet gas, the coated circuit tubing. We used a cardio help system and an HLS-7 oxygenator. The oxygenator itself was completely unmodified. And we would follow these animals for 72 hours. We didn't give the treatment nitric oxide group any systemic anticoagulation other than a bolus at the time of cannulation. And then for our control group, we just use an HLS-7 oxygenator as is from the manufacturer. And we do give systemic, continuous, unfractionated heparin infusion to target an ACT of 150% at baseline. And our key outcome measures were to look at safety of the approach, also functionality. We want to make sure the nitric oxide isn't affecting gas transfer through the oxygenator, and then a extensive look at blood compatibility. I have a lot of results to show here. I just want to give an overview kind of the types of results that we're looking at rather than digging into each result in a lot of depth. I also encourage if you're interested in this to look at the paper because there's a lot more in there and in the supplement. We did have one circuit occlude over 72 hours, and that was in the control group that was systemically heparinized, but no circuit occlusion in the nitric oxide group that didn't receive heparin. No difference in bleeding complications between the groups. We don't give a blood transfusion to these animals, and so we do indicate whether a transfusion would have been indicated. And there was no difference between our heparinized group and our sweet gas nitric oxide group. We looked at nitric oxide metabolites. We do see some increase in nitrate and nitrite levels in the nitric oxide groups, but not at levels that would be concerning. They're similar to a study where healthy people drank beet juice and they looked at nitrate and nitrite levels. We look at protein nitration, systemic methemoglobin levels, cytokines, damage-associated molecular patterns, renal injury markers, and not seeing any significant differences between the groups or cause for concern. We look at a lot of different vital signs, mechanical ventilator settings, blood gases, fluid balance, and don't see any difference between our groups. One thing that was interesting, though, is we do see kind of this signal towards a lot higher fluid balance in the control group versus the nitric oxide group, which is something that we think is interesting and should really be looked at more closely in the clinical sphere as well. With respect to functionality, we didn't see any effect of the sweet gas nitric oxide on oxygenation, oxygen transfer, carbon dioxide removal. This is that the nitric oxide flux across the oxygenator over time. We don't see a difference in the pump speed, the RPMs, the circuit pressures between groups as well. Looking at hemocompatibility, we do see significant platelet loss in both groups. So this is something we've consistently observed is that we don't see preservation of the platelet count in the nitric oxide group. We're not systemically anticoagulating. We're just relying on the nitric oxide in this heparin-free approach. But that's something that we've noted. Otherwise, looking at our coagulation panel for hemoglobin, there's no difference between groups other than the PTTs are higher and the ACTs are higher in the control group that's being heparinized. And then looking at our platelet activation and aggregation metrics, we don't see group differences here in stimulated aggregation, in platelet surface markers of activation, or in platelet factor 4 levels released from activated platelets. We looked at some other hemocompatibility metrics that we don't traditionally think of with respect to nitric oxide, just to assess the effects of systemic anticoagulation itself as well. So we do see, interestingly, greater loss of von Willebrand factor multimer size in the nitric oxide group, better retention of the multimer size in the control group. That was something we didn't really expect and we're kind of digging into more. This was, it did not result in a clinical manifestation of a bleeding difference. So acquired von Willebrand syndrome is something that's being talked about more and more in the extracorporeal support space. We see a difference in groups in the multimer size distribution, but again, no clinical manifestation of bleeding. The bleeding and thrombotic complications were the same between groups. We look at viscoelastic tests, and then we see some really interesting effects on thrombin and antithrombin dynamics. So this is our nitric oxide group, and we see that antithrombin kind of rebounds and escalates. So we may see some kind of signal towards enhanced activity of endogenous anticoagulants when we're using nitric oxide and not using systemic anticoagulants versus our control group where we see this reduction in the antithrombin activity once the animals are heparinized. And that also manifested in this is a measure of the total thrombin generation. So we see greater thrombin generation in our heparinized animals compared to the nitric oxide animals. So that could be related to effects of nitric oxide on inflammatory mediators and subsequent thrombin generation. We do a lot of work with oxygenator dissection. We saw in this study that the oxygenator thrombus coverage was significantly reduced in the nitric oxide animals compared to the controls. And again, these controls are heparinized, the nitric oxide group is not. So this is a very promising and exciting signal that we're seeing here. So since this study, we've also evaluated the sweep gas NO with the same coating, same dose in a 72-hour polytrauma model. So the animals encounter pulmonary contusion and hemorrhage prior to start of ECLS. We've also repeated the study in both uninjured and injured animals that get the same sweep gas NO, but with a different type of coating that's a non-adhesive surface and has a nitric oxide eluting compound. And we've also done some work looking at the combination of lung and renal support using only sweep gas nitric oxide as the anticoagulant approach with just from the manufacturer heparin-coated circuits. Across these studies, which encompass over 50 animals, what we're consistently observing is that the sweep gas nitric oxide groups without getting systemic anticoagulation are having equivalent or lower thrombus deposition on the oxygenators compared to our systemically heparinized controls. And we're not seeing a difference in bleeding or thrombotic events between the groups. So this is promising. These other studies that I mentioned are all kind of in progress or in process of publication right now. So a lot more exciting work to come. We're also taking samples from these studies and doing some cross-study analysis, looking at, like I touched on before, some of the antithrombin and thrombin dynamics, the von Willebrand factor effects, and then we're also really interested in platelet receptor shedding, looking at that as a process of platelet turnover, since we're not seeing this clear signal with respect to platelet preservation, looking at enzymes that come and cleave the receptors off of platelets so they're unable to interact with each other, and it kind of marks them for faster turnover. So that's something we're also trying to dig into deeper. And these are all areas of interest that we're really seeking clinical collaborators as well. All these assays that we do are actually adapted from human assays for swine, so they're easily done in human samples, and we'd love to work with different clinical centers on this. We have worked with and like to continue to work with clinical collaborators with respect to the oxygenator analysis. I put this together. This graph represents almost 60 animals, looking at uninjured heparinized control animals and thrombus deposition compared to uninjured nitric oxide, no heparin animals. And again, here's the injured versus the uninjured or versus the injured with nitric oxide. And again, we're seeing either improvement or no difference in clot deposition when we're using that nitric oxide sweep gas. Like Dr. LaRussa had mentioned, we definitely see the need for translational animal studies and even in a multi-center setup to kind of dig into some of these questions that are difficult to address in the immediate and the clinical realm just because of the complexity of clinical care and the patients being cared for. And so we just threw together a couple of points of how could such a multi-institutional study be conducted. I think our research priorities are pretty clear. We need to understand better, is sweep gas nitric oxide beneficial? We see a lot of anecdotal evidence, but how specifically is it working? What is the best efficacious dose? And also what patients and ECLS indications is this appropriate for and would most benefit? I think some important factors we need to think of in the research study design are, first of all, what species is the best to involve in such a study. There's a lot of species variation in platelet function compared to humans. There's a lot of animals who their platelets don't agglutinate the same way as human patients. They don't react with biomaterials the same way. Some animals compensate for having less reactive platelets with higher platelet counts. And so there's just a lot of variability here. So trying to find the best, most representative of human species we can include. What are the key outcome measures we should be looking at to power such a study to? What doses of interest should we look at off the bat? What ECLS indication, what injury model, what type of flow rates should we be looking at, what kind of ECLS device? I think all these things can affect the efficacy of the nitric oxide, what type of study duration, and then for translational studies, just like for clinical studies, standardizing how we report on bleeding and thrombotic outcomes, our management and our interventions is going to be key to coming up with results that can be acquired at a multi-institutional level. And also, importantly, the funding mechanism, already in this very challenging funding environment, finding the right group that understands the necessity of this research, the importance, and can really back this work is going to be critical. So with that, I'll share, this is our program information, and Dr. Baczynski and I are happy to take any questions. Thank you very much.
Thank you very much, Taryn, and thank you, Andrew. Clearly, this is going to be an important part of the ongoing collaboration and discussion. Please, can you put things in the chat or save them for the discussion at the end of the webinar? I'm now going to introduce Alison Weinberg, who is been involved with devices. She's a perfusionist, and she set up the ELSO registry device section with some colleagues, and has also been involved in the ELSO bedside guide. And she's going to talk about oxygenator lifespan. Alison.
Thank you, Giles. Can you see my screen? Can you guys see my screen?
Yes, we can.
Yes.
Okay, great. Well, my talk is nowhere near as scientific as everybody else's, but I am going to talk about oxygenator lifespan, which seems like a fairly easy topic, but it's not quite as easy as it sounds. I do not have any disclosures today. So oxygenator failure, you see before you ELSO's reasons or criteria for oxygenator failure. They're pretty fair and they're pretty commonplace for today. But the circumstances surrounding these criteria are really quite subjective. What we deal with are structural integrity, the decreased efficiency of gas exchange, acute obstruction to blood flow, increasing resistance to blood flow, coagulopathy with membrane lung as a known source, hemolysis, and the entire circuit being replaced due to hemolysis of an unknown source. All right, so what is the norm exactly? So we know that ECMO has been around since the early 1970s for adults as well as the pediatric and neonatal population. Thankfully, we don't have these oxygenators anymore. Our beloved Dr. Bartlett was responsible for Esperanza on the right, but these oxygenators are no more. Today we have other choices, and I'm sure, I have no doubt there will be more to come. But today we're going to focus on how to recognize what we have and how to handle the cards that we're dealt with. Really how to come together and make a consortium to move forward together to make a better tomorrow, really. All right, so we all know what a healthy oxygenator looks like. That's not really why we're here today. We don't know how to really always recognize or deal with what a failing oxygenator is, because it has many faces to a lot of different people, really. So where do we start? Well, the healthy oxygenator, we know we have to get our baseline values, and there are a lot of different baseline values. We know we have to, when we go on, get our RPMs and what flow did we get for those RPMs and what was the pressure drop, what did the oxygenator look like visually, and what was the sweep and FiO2 for the flow. We always want our starting hemoglobin, it's very important. What's the patient's saturation? now both for their body and the saturation going into the oxygenator, and of course, what mode of ECMO are we on? Then we go from there, okay? And then where are we now? Is there a problem? We probably would not be discussing this if there were not a problem now, right? So then we look at what are our values now, and how many RPMs do we have for any given flow now? Are there more RPMs to achieve the same flow? And is our pressure drop different? And what does it look like visually? It may not look any different visually because the problem may be inside of the actual oxygenator, right? We may not see clots visually because platelets may be balling up inside. And do we need more sweep or FiO2 for any given flow? And have we lost hemoglobin and the capacity to carry the oxygen to the body? And of course, we always need an oxygen transfer equation to see what we're doing across the oxygenator. We look at the patient's saturation again in the body and going into the oxygenator, because although the patient's saturation may be low, we know we can only do so much with what's coming into the oxygenator. So while we think it may be failing, if the mixed venous is 35, we know we're not going to get a great saturation coming out. And again, we look at what the mode of ECMO is. Do we need to add more cannulas? All right, so what is the real problem? We may not have a failing oxygenator. We might have providers that don't have agreement on how to treat what one may suspect to be a failing oxygenator. More importantly, we may not have a consensus on what that failing oxygenator may actually be. What do you do about this problem? Okay, what's the answer? Well, right now, we really don't have an answer. What we need is an information system on how to make an informed decision on what a failing oxygenator actually is. We need an agreement of treatment choices to make an informed decision plan. We have all of these scoring systems within medicine, right? We have Apache scores and Murray scores and REST scores. We don't have oxygenator predictive scores, and that's really not all that easy. But we can begin collecting data. We can begin with the consortium, and we can agree that as a community, we'll begin to collect this data and start analyzing the data, and we can make it mean something. But more importantly, it's already in the registry for us, and we can make a standard. We can use this consortium to publish. And we can publish often, we can publish cases, we can publish techniques. We can publish so we may continue to move ECMO forward the way Dr. Bartlett intended to do, so we may continue to honor him. Okay? The ECMO lung failure addendum that we would like to begin to propose was last updated on January 1st, 1989, when ELSO first started coming together. And it has the definitions for failure as it's defined by ELSO now. And it has all of this data that's in the registry now, but it doesn't have it all in one place. So we can make a defined scoring system out of it. So we may begin to make a defined scoring system out of it. So why not get it together all in one place so we can see what goes into oxygenators failing? We don't know what contribution factor 7 makes to it. We don't know what contribution acute PEs or chronic PEs or ECPR or HIT or all of these conditions that we did not recognize in 1989 make to it, or adding nitric oxide to the circuit makes to it. So why not put it all in one place and gather the information and publish on it? Why not put it all in one place so we may begin to make scores so we can make a more reliable prediction on how to change an oxygenator, if it's failing, when it's failing. Thank you, guys.
Thank you very much, Alison. That was a fantastic gamble through, and I certainly hadn't realised that we hadn't looked at this since 1989, which was the year before I graduated from medical school. Fantastic news that we're going to do something with this. Now I'd like to introduce Dr. Adrian Matke, who's going to tell us about the NECTAR trial, and then we're going to leave him to a discussion following this. Adrian.
So I'm hoping that everyone can see this. Okay, and then let's see whether we can go into presentation mode. All right, so thank you for the invitation. I want to just present the results from the NECTAR trial that we put together. The NECTAR trial was a trial of nitric oxide put into the sweep flow, and we published the protocol. The trial, unfortunately, is not published yet. It's sitting with Robert Tasker. And as soon as he says, okay, then hopefully it'll come out. So we're hoping it will be published in the next couple of weeks. We enrolled between 2019 to the end of 2023, so we're a bit overdue to have this out. So what we tried to look at is, what difference would nitric oxide make? And we looked at safety, feasibility, and then an effect estimate. It was a pilot trial, and it was really designed to see what could a definitive trial look like. And the safety was MET-HB, sweep gas interruption, circuit changes, feasibility, recruitment, consent rates, and then the effect estimate you can see here, survival, blood product use, circuit changes. And then we looked at inflammation and coagulation activation measurements. So being sort of a little bit more detailed, the clinical parameters were survival free of ECMO, survival free of PICU, and hospital length of stay. You can argue whether that's a right measurement, but we did this to basically cast a wide net. We did laboratory parameters, which was D-dimers, free plasma HB, inflammation markers, coagulation markers, endothelial activation markers, and then we measured the circuits with a CT of the oxygenator at the end of every run to measure the thrombus in it. There's something called the ELSA monitor, which is a dilution technique where you can basically non-invasively measure what is the current volume, and then if you subtract that from the total volume, you can have a proxy measure for thrombus, and we measure the transmembrane pressure. It was a prospective pilot randomized trial. It was non-blinded. The blinding technique isn't possible because the injector module we used has a ticking sound, and so we couldn't blind it. We had a target recruitment of 50, which is recommended for exploratory trials, and it was single center. We offered it to other centers in Australia, and unfortunately, they didn't come on board. So that's what we used. We used the Sophenox machine, and you can see here the injector module that is in here. That's basically just cut into the gas line that goes into the oxygenator. So we had 60 patients, 53 of which underwent randomization, and 25 were assigned to nitric oxide and 28 to standard care. When you look at the characteristics of the group, so this is all in pediatrics, it's not in adults. You can see here months at randomization, 6 months versus 1 month in the two groups, with a sort of comparable weight. And then you see the admission diagnoses here. And what I found interesting is that even though we had a low number of patients, there was a relatively equal distribution of the various disease groups. When you look at the type of ECMO, type of support, and type of ECMO consults that we used, again, VA was sort of similarly distributed versus VV, and pulmonary cardiac versus ECPR with 53 patients was equally distributed. You can see the type of ECMO consults we had, the PLOD at baseline, and the MET-HB more than 3% at baseline as a safety parameter. So when we look at the effect estimates that we got, so we looked at survival free of ECMO censored at 30 days, and you can see here that the standard care had a bit longer survival free of ECMO than did nitric oxide, although this is not statistically significant, it's just numerically different. And the same is true if you censored at 90 days, and then the hospital length of stay was actually slightly shorter in the nitric oxide group than in the standard care group. These are all, when I say shorter and longer, I don't mean this in a statistically significant way, I just mean that numerically. So then when we looked at the safety outcomes, we looked at the MET-HB elevations more than 3% and how many events were there. And what was interesting for us was to see that if you have a lot of free hemoglobin, that actually elevates the MET-HB, and we could see in sort of severe septic patients that we sometimes put on, those were the ones that had MET-HB elevations independent of whether they had nitric oxide in the sweep flow or not. You can see here the circuit duration without needing replacement, which was 106 hours and 142 hours. I'm not sure that that means much, simply because they weren't replaced. They were just running out. Now, when you look at the ones that needed replacement, we had a much longer number, at least in the standard care, than in the nitric oxide care group. When you look at the hemorrhagic complications and the type of hemorrhagic complications, they were similar between the two groups in terms of 3 plasma HB, surgical site bleeding, cannula site bleeding, and so on. We then looked at what was the blood product use that we had between the standard and the nitric oxide group, and you can see here that they were quite similar actually between the group. And then we drilled down into that a bit further, and we looked at the median daily red blood cell use in mils per kilo. And then we looked at it, because it doesn't make sense if you do it per day, we then did it for when it was actually, how many number of days were red blood cells given, and that was in 30% of days. And then how much did we actually give? 20 mils per kilo, I guess that's sort of the recommendation that you would give these days. We then looked at all the other blood parameters, and I won't run you through every single one of them. The bottom line here is that we looked at the platelets, we looked at the cryo, looked at FFP, and none of them actually showed much of a difference between the groups. We then, as I said to you, we CT deoxygenated at the end of the run. We had a standard operating protocol for how we would flush the oxygenator out at the end of the run to make sure all the blood went out. We flushed it until, like, with a low gravity flush, so the clot wouldn't be flushed out. And then we put it through a CT scanner, and then a radiographer actually defined the clots for us. You can see here the 3D model, and here the measurement of the clot. And there was no difference in the median clot size between the two groups. Then we did some lab measurements. You can see here these biomarkers that I won't rattle off, but you can see it's roughly sort of inflammatory markers, platelet activation with platelet factor 4, ADAM TS13, some endothelial activation with p-selectin, and so on. We measured them before going on ECMO, 1 hour after going on, 12 hours after, and 24 hours going after. We were limited by the amount of money we had. We would have loved to measure them a bit longer, but that wasn't possible. And what you can see here, what's sort of interesting is this is, NO is the blue, red is the control, and green is the overall. And you can see that they all have sort of this dip here in the beginning where they go down, and then they don't do much thereafter. And people were arguing whether, you know, we just have hemodilution basically, and that's why they drop in the beginning. But some of these markers actually have an extraordinarily short half-life, somewhere between 30 minutes and maximally an hour. So even if that dip was there, then they should have shot right up thereafter, which they didn't do. And we compare that to the Melfordheimer paper that was mentioned earlier, you know, where they see this beautiful elevation here of IL-8 and TNF-alpha. We just didn't see that in real life. We measured complement. You see that's, and I don't mean to be facetious, but it gets really boring, a bit of a drop, and then it's just flat. CD40 ligand, p-selectin, TNF-alpha, they all had this drop and then not much thereafter. When you look at the ADAM TS13 and the platelet factor 4, it gets a little bit more interesting, is that it zigzags up and down a little bit. But again, there isn't sort of, when we all talk about the cytokine storm and that nitric oxide would be great for the cytokine storm, we just couldn't identify a cytokine storm happening in our patients. And then as a last thing, what I just want to add is we're currently doing a study with ELSA data for where we took the last 5 years of all pediatric patients and to look at how long would a circuit last, what is the normal duration that a circuit would last. And we have 21,000 patients with 26,000 circuits. And this is what my statistician sent me today. So it's really completely unvalidated and not a proper form yet. But you can see here that sort of one circuit is 21,000, and then two circuits is 3,000 patients, and then 3, 4, 5, 6, it drops down as you can see here. And then when you look at how long do these circuits last, you can see that the median here is 114 hours with a mean of 167. Obviously, it's skewed because there's a long tail end. You can see here that sort of the duration that circuit lasts at 95th percentile is 484. And we thought that was quite informative in terms of, if we did a study and we focused on circuit replacement, we'd be a bit disappointed because there's actually only sort of 20%, 15% to 20% of patients that actually need a circuit replacement. So you need a large amount of patients if you wanted circuit replacement to be your target that you would go for in a trial. And as a last slide here, I wanted to show you this because I thought that was interesting. Dr. Lurister before mentioned inhaled nitric oxide, and there's this meta-analysis that was done by this group here, where they teased out a bit of a positive effect from inhaled nitric oxide. And so I was wondering, did we just use the wrong membrane? Should we have just given it into the lungs? Because it's biologically a much better suited membrane, let's say, and therefore might be more efficient. So summary, we demonstrated that an RCT is feasible, at least in a single center and in the Australian environment. Nitric oxide is safe, the clinical effect is uncertain, and the endpoints were feasible. We demonstrated that the CT scanning is sort of quite elegant. We had a 30% replacement rate, and in the ELSA data, 20% as a consideration of, what would we do with a definitive trial. We had divergent cytokine patterns after ECMO commencement, but we didn't see an SNO effect on these cytokines. So the paradigm of a cytokine storm, we actually had to question, at least in our cohort. I'm not saying it's universally true, but it certainly wasn't true for us. And then the future outlook, someone else has already mentioned this. Karen mentioned sort of what should we target, and there's a few acknowledgements. Thank you very much.
That's fantastic, Adrian. You are leading this field clearly, and I'm really grateful to be a collaborator and that you've come into this meeting. Interestingly, that you didn't see any change in the cytokines and also the registry data on the oxygenator life. So we've clearly got a lot of thinking to do. Now, I apologize to everybody for the beginning of the webinar. I was going to share you a couple of ideas, and as the chairman, I'm going to take that prerogative now and hopefully share those very quickly before we go into our discussion. So I apologize for my ineptitude here. Right, can everybody see that?
Yes.
Yeah, good. Okay, so let's couple of things that I didn't say before, which I'd like to, which is how we came up with the name SNOOPI, and it stands for Sweet Nitric Oxide Observational and Prospective Investigators, which is a bit clunky, but I think SNOOPI is a good name for a research group. So that's how we ended up with that. ECMO is a team game, and of course, Dr. Bartlett and Esperanza in the center of this picture is very important. I'd also like to re-acknowledge the contribution of Dr. Bartlett with pushing this nitric oxide work, and of course, Gail Anich was who is on the call, which I'm very grateful for, was his major partner in crime in this when this was first started, and it's continuing in the lab now. And in fact, Bob called me about 2 weeks before he died to talk about nitric oxide, sharp as a tack still. So he's clearly very interested in this right up till the end. Now, this quote from Epictetus is really important to what we're doing. If we already know what the answer is, we're not going to be able to find the truth. So we have to try and work through it. And then hopefully we'll end up like Winston Churchill here, that people will be asking us the way to do it. Now, I'm going to finish my comments with a campfire story, which a lot of you will have heard before. And this is a patient that we looked after here at UF just over 18 months ago with basically polymicrobial pneumonia. And she was on ECMO for a long time. And she had no lung function and was on VA and then VV and very complicated long-term course and massive team effort to get her through it. And I decannulated her on her first birthday after 234 days on ECMO. And we took her to walk on ECMO. And during the course of her run, she had 3 circuit changes, which I think agrees with what Adrian told us. And this is her membrane after she came off that was cut in the Ariva lab with Dr. Baczynski's team. And you can see it's absolutely pristine with the SNO. And that's her a couple of months ago. So she made a complete recovery. I personally think that the nitric made a massive difference to her, particularly in terms of reducing the number of circuit changes. You know, clearly we need more study, and that's why we're here. And so what I'd like you to think about going into this discussion is these things here. You know, if you're using it clinically, write it up. If you've got to take a patient off IV anticoagulation, be that heparin or bivalirudin, consider using it. We should definitely look at the membranes, and I'm sure Andrew would be happy to collaborate on this, and you can email him, and equally you can email me. So I'm going to leave you with this, which is written on the wall of Bartlett's lab, which is 10 years from now, grateful patients will be alive because of the research we're doing. They won't know how or why it happened without complications, but you will. So I would suggest that this is an ongoing part of that journey. And now I'm going to hand it over to my co-chair at the discussion, Dr. Graham McLaren.
Thank you very much, Giles. And thanks to both you and Zasha for putting this webinar together. I'd also like to congratulate Adrian Matke for staying awake. I think it's after 12:30 in the morning in Brisbane right now. So thank you for that. And I don't want to sound like a broken record here, but I think it is important that we all acknowledge the loss that we have felt since Dr. Bartlett has died. I have worked with him on a few projects, and I think he's the nearest individual to approaching genius level intelligence I've ever had the pleasure of working with. He had an extraordinary mind, and coupled with that, he was a very humble, lovely man. We have really lost a great deal. Moving back to nitric oxide for a second, I think it's very clear that the ECMO community likes a good theory, particularly in neonatal and pediatric ECMO. Unfortunately, sometimes a good theory isn't enough. And I think we've seen a few examples of the cart pulling the horse, one of which, to take an immediate example, is antithrombin administration, where the theory has been there, people have just leapt on it without adequate data. And I think if we look at what we're discussing now, which is administering nitric oxide through the sweep gas, there's a number of considerations. First of all, is there biological plausibility? And I think from the last hour and a half of presentation that we clearly have biological plausibility. Second consideration is safety. Do we have adequate safety data? And I would argue that thus far we do. We have several hundred, if not more than 1,000 patients who have been exposed to nitric oxide in the sweep gas, and there don't seem to be any adverse effects. Yes, the RCTs are small in number, but there doesn't seem to be a major signal towards inadequate safety data, even to the same extent that there is within inhaled nitric oxide. Third question, of course, is technical considerations. So how do we do this? And I think this has been published sufficiently over the last 10 years that we know how to administer nitric oxide. As we get down this list of mine, of course, we start to lose the thread of the argument. We have no idea what dose to administer. So the dose, as has been apparent in the discussion, is unknown. We have good data on the proper dose of inhaled nitric oxide, but we do not have it for nitric oxide administered through the sweep. And of course, much of this discussion has been about the effects. We have mixed signals in the literature about the effect. One thing that we haven't talked about at all, if my
Hey,
memory
Graham, I'm
doesn't-
sorry to interrupt you. I'm not sure you're aware, but we see your desktop. Are you meaning to show it, or are you meaning to show slides? We can't see your slides.
That's not me, Andre. I'm just talking.
Oh, okay.
Yeah, that's somebody else's slides. But thanks. So the final point I'd like to bring up is the cost. Now, when people talk about the cost of ECMO, they kind of dismiss it and say, yes, okay, fine, it's expensive. But nitric oxide is not cheap. And the administration of nitric oxide through the sweep in low and middle income countries would carry a substantial burden to the patients who have to pay for it. And before you all rush to judgment and say, oh, that they don't do ECMO in low and middle income countries, yes, they do. I've run ECMO workshops in middle income countries, at least 6 of them within a 4-hour flight of Singapore. So they do offer it, and cost is an issue. Getting back to Giles' comment, I would like to say when I've used nitric oxide in the sweep, the first time I ever did it, I was absolutely astonished anecdotally by how effective it seemed to be. Now, thankfully, this is one of these webinars where there may be more expertise in the audience than amongst the speakers and chairs. So what I'd like to do is to start this discussion. I know, well, I hope Gail Arnach is still online. Gail is a very senior pediatric intensive care physician from Toronto Sick Kids, and worked with Dr. Bartlett for many, many years on nitric oxide releasing polymers. I know we've heard from Drs. Baczynski and Peters about this, but I would love an independent opinion. Gail, where do you think this stands? Do you think that nitric oxide releasing polymers are the way of the future, or nitric administered via the sweep gas? Thank you.
Well, thanks, first of all, for inviting me. I wasn't in my Monday morning plans, but I'm really excited to see such a interested group of people here. So really excited to see the work and the interest that has come forward with the use of nitric oxide. As many of you know, over the time of working with Bartlett, I've been a massive fan of the use of nitric oxide and the development of these polymers. And there's another Gail Arnach on the line, but it's actually Mark Meyerhoff, who is the other pioneer that worked with Dr. Bartlett. Mark can put on his screen and sort of make some comments as well. But the journey that we've had together to develop these, and then with Alvaro and the crew to to move forward with it now is very impressive, and we're seeing some of that work. I think certainly the journey of using nitric oxide, I think we have to be careful to think that we don't impede other things by its use. And certainly when we created the polymers, we loved what we saw, and the proof of principle was incredible. But one of the things that we then realized in the use of these polymers and just using a platelet inhibitor, such as nitric oxide for local effect, was that we then created a fibrinogen consumption. So we were inhibiting some of the obviously primary hemostatic response at a local level, but then consuming fibrinogen onto the circuitry and actually creating a deficit of fibrinogen. And we showed some of that in the second paper that we published later on, when we demonstrated a more effective model of having something that could stay in the organic phase. And so then that was the implementation of a thrombin inhibitor such as argatroban to prevent that adhesion. I think we have to be careful when we think that we're able to inhibit platelets, because that was my belief at the beginning. As you age, you tend to learn that your cavalierness needs to always be brought back to reality, and you need to look at other things. And so that was the next journey that has then been demonstrated in the lab with the NOSA compound. I think when you're looking at nitric oxide and believing that you can purely put it in the sweep gas, you have to remember that its metabolism is within milliseconds. And so it may make your oxygenator look better. And then again, it may not. It depends what that debris, or is it clot on the oxygenator. So I think there's a lot of variables to that. So I think the inhibition of it sticking to the oxygenator is, I think there is a lot of merit in it, but I think we have to have a very standardized approach and a careful and safe approach to it, because the way we administer nitric oxide across the world is variable. And I think this is where a NO generator is maybe what we need to look at, rather than using what we use as a gas in the ventilator as the system that we would use in the sweep gas. And so those are some of my thoughts on it. I still think that you need a circuitry that actually, from cannula through to the reinfusion cannula, has some ability to locally inhibit clot formation and platelet activation at that line. Do I think that we need to endothelialize the circuit? I used to believe that. I think that that is not the right way to go, because as everyone is talking about in the chat, what do you do with a septic patient, a hyperinflammatory patient? And in those instances, we know that the endothelium itself is affected and we have endothelial dysfunction. So I think that we probably need to focus on a few core things to help us to inhibit the clot formation, which I do believe nitric oxide is very valuable in that. But I don't think it solves all your problems. And I don't think it necessarily solves the problems of cytokine release and all of those things, but I think it can help to keep your circuit stable as we are challenged with treating the underlying cause. I'd invite Mark to make a comment, because we've been at this for years.
Thank you, Gail. I appreciate it. Well, I'm a basic scientist. I'm a chemist, and I started working with nitric oxide back in the late 90s, trying to create polymers that would release nitric oxide, with the idea that we'd be able to make a circuit where the NO would come out locally. So, the problem is nitric oxide is immediately consumed by hemoglobin. It reacts very quickly. So making it somewhere else is not a good idea. You have to release it very, very locally to have an effect. And we worked with Dr. Bartlett. I remember him. I always say that he was an amazing, amazing down-to-earth person. When we started with nitric oxide, we used to have every couple of weeks a meeting at a Starbucks near where the chemistry lab was. I think Gail used to come to those meetings periodically. And he was still active as a doctor at that point. He would come to those meetings periodically to give his input. I had my graduate students and postdocs at the meeting, which was always amazing to me that he would take time out and come. I'm a basic researcher, and he was a famous doctor, yet he would come to those meetings. That was very, very special to me. But at any rate, all the experiments we've done with Gail and other people, when we do locally with catheters that release nitric oxide, where the NO is coming out of the polymer, not feeding it into the blood, we always saw, in animal studies, not in humans, but in animal studies, there was always a dramatic effect on the reduction in clots formation on the surface. So, it's a very big different story when you're feeding it into the bulk of the blood versus producing it locally. And I think locally, for sure, it works. Whether it works in the way you're doing it, where you're feeding it into the oxygenator, that, it's gone. It's immediately gone. There's no NO when you go downstream, because it reacts immediately with oxygen, so with the hemoglobin, oxyhemoglobin. So that would be my input to the story, Gail.
Thanks very much, Dr. Meyerhoff. We appreciate that. One person who's also, I think, listening in, who's published a lot in this field, is Professor Paul Kekia from Texas Children's. If we go back 10 years and look at what this space was doing, not in terms of nitric oxide releasing polymers, but in terms of administering nitric oxide through the sweep gas, There was a study published in 2016 in intensive care medicine from the Royal Children's Hospital in Melbourne, which looked at SNO administration during cardiopulmonary bypass. And it showed there was about 200 children involved, and the ones that got nitric oxide needed far less ECMO. I think 8 in the control group and 1 in the treatment group, much lower low cardiac output syndrome. But one thing that was noticeable in that particular study was that the smaller the child, in terms of both age and weight, the more dramatic the response. Paul, could you comment about this in particular? Obviously, people listening in on this webinar come from many different backgrounds, but I think particularly in neonatal and pediatric intensive care, there is a signal that the younger the child, the more dramatic this effect can be. Thank you.
Yeah, hopefully everyone can hear me. One of the things that I think, as I'm listening to this, it's interesting how I come at it from just a slightly different viewpoint, which is, while I'm interested in the coagulation cascade and the circuit, I've always been intrigued by, in our study and others with cardiopulmonary bypass, the reperfusion injury. And I think that's what you're speaking to, Graham, which is the bioavailability across multi-organ systems of nitric right at the point of ischemia reperfusion injury, I think is what always intrigued me in this space. And that could speak to the fact of whether it be the availability of nitric right at the point of injury, and I think that's where the size factor comes in. So when I first saw the webinar come up as an invitation, one of the things that immediately struck me is the opportunity to not only look at the use in ECMO across the sweet gas, but specifically in a population of ECPR. And I think that would be the most intriguing from a study design perspective, to be able to say, as we're reperfusing in the middle of CPR and we start the ECMO circuit and have a huge bioavailable sink, as it were, within the oxygenator ready to deliver to the patient, also really helps with an outcome study where we can really see that there's an impact there. I think that's where everything you talked about in terms of size of patient, bioavailability, delivery, could be a point where everything kind of comes together.
Thank you. I couldn't agree more. And the times that I've been most impressed using this clinically was in infants who had ECPR, who I was convinced were going to die, and they didn't. And obviously, we're not here to discuss anecdotes, but I think you're almost certainly right. I think that small children having ECPR is the perfect example of this technology. So we're slowly running out of time. I'm going to hand back to Giles to wrap up the session, unless there are any more burning questions. Thank you.
Thank you very much, Graham. I'd like to thank everybody for contributing, and I've really enjoyed the insights of both the, as the hymn book is called, Ancient and Modern. It's really something that is been looked at in a number of different aspects in both bypass and ECMO, and we clearly need to move forwards. Now, I'd like to encourage anyone that's got anecdotal experience to report that experience as case reports, as the first part of this SNOOPI experience. And secondly, there's been some great ideas about what could be done. Both Roberto's multi-lab idea, the existing labs that are already working on it, and Adrian Crucian was suggesting ways in which we could collaborate using sending membranes that had been exposed to SNO. So I've put my email address in the chat. Please email me if you want to collaborate or have any ideas or whatever. We have the recording of this, which we're going to put online and make it available to everybody. I hope that we'll have further meetings going forwards where we can talk about our ongoing studies. And I'd like to encourage everybody to get in touch, both face-to-face at the ALSO meetings and also virtually. Thanks once again to all the speakers, and to my co-chair, Dr. McLaren, and unfortunately Roberta had to go. So have a great day or night, and thank you very much, everybody.